Great. Thank you so much, Megan, for the introduction. And thank you everyone for being here today with us. My name again is Anisa Ali, and I use she, her pronouns. And I am a senior program specialist at Futures Without Violence. And I'll let my colleague introduce herself as well.
Hi, everyone. I'm Abby. My pronouns are she and her, and I am an MSW intern on the health team for Futures Without Violence.
Thanks. So if you haven't already, please feel free to introduce yourself in the chat. We'd love to hear your name, your pronouns, your role, and where you work. I see some folks are already doing that, so we will revisit that in just a second. So just a little bit about Futures. So we are a national nonprofit organization based in San Francisco, and we work to address violence and abuse across the lifespan. So the work that Abby and I do is focused on the health impact of violence and abuse, and we work to improve the healthcare system's response to violence. And we are also home to the National Health Network on Intimate Partner Violence and Human Trafficking. And this is a national training and technical assistance partnership for community health centers, which is funded by HRSA's Bureau of Primary Health Care. And we'll tell you a little bit more about that in just a second. Or sorry, at the end of our presentation today. So the goal of our presentation today is to talk a little bit about the dynamics and prevalence of intimate partner violence, also some considerations for IPV, intimate partner violence, among migrant farm workers, how health centers can address and prevent intimate partner violence with an evidence-based clinical intervention, and how to partner with domestic violence advocacy programs to help address the health needs of survivors. And next slide, please. So just a couple notes on the technology. I know we're all super used to Zoom by now, but just to note that you can use the chat box for any questions or comments throughout. So we will have time for questions at the end, but feel free to drop them in the chat as we go, and we'll make sure to address them as we go along. And when you're doing that, just make sure in the chat box that you click all attendees and panelists so it goes to everyone, otherwise it'll just go to all panelists. And next slide, please. So before we get started, I know a lot of us have been sitting all day, so we wanted to just take a minute and have a brief stretch and breathing break. So for this, you can either stand up or stay seated, and just know that you can do whatever is most comfortable for you. So I'm just going to go ahead and stay seated. So I'm just going to, and again, feel free to just get in whatever position is comfortable for you, but I'm going to sit a little bit further up in my chair, put my feet on the floor, my hands on my knees. And so you can just stretch out your arms at your side. And as you do, have your palms up straight, and just bring them up as you breathe in. And then as you breathe out, just go ahead and bring your fingertips down and touch the tip of your shoulders. Breathe out. And go ahead and do that one more time. Breathe in. And breathe out as you touch your fingertips to your shoulders. And go ahead and do that one more time. And breathe out. Feel free to open your eyes when you're ready. If you close them, and just go ahead and shake it out. Okay, so before I turn it over to Abby, I will just going to take a look at the chat and see who we have in the room. So I see we have some folks from Oregon, Colorado, Family Health Center in Colorado, Head Start in Massachusetts, Behavioral Health Consultant North Carolina, Valley View Health Center in Washington. Also, thank you, Brenda, fierce advocate of women survivors of domestic violence. Thank you for that work. And then a Bay Area advocate for homeless and people in need. And then also some folks from a community health center in Oregon. So thanks everyone for sharing in the chat, and please feel free to continue to do that. Kind of just gives us a sense of who's in the room today. And I'm going to turn it over to Abby.
All right, great. Thanks, Anisa. So some objectives that we have for today. First, we're going to learn about the prevalence and dynamics of intimate partner violence among migrant farm workers. Second, we'll understand common health issues impacting migrant farm workers experiencing intimate partner violence. And then finally, promote meaningful and effective collaboration between domestic violence advocates and community health centers as a critical strategy to support migrant farm worker survivors. Okay, so what is intimate partner violence? Here at Futures, we use this definition. One person in a relationship is using a pattern of methods and tactics to gain and maintain power and control over the other person. And I really want to emphasize here that this is a pattern and that it is for the intention of power and control. This is often a cycle that does get worse over time. So with that pattern, meaning that it's not a one-time incident. Abusers may use jealousy, mental health, money, and other tactics to be controlling and abusive. So it's not just physical violence. Finally, leaving an abusive relationship is not always the best, the safest, or the most realistic option for survivors, which we'll talk about in some more detail here in just a minute. I also want to note that in this presentation, we're going to be using intimate partner violence and domestic violence interchangeably. Domestic violence is more of a broad umbrella term that encompasses different types of family violence, but we'll be talking about both today. So legal definitions are often more narrowly defined with a particular focus on physical and sexual assault. So you'll notice if you're looking at laws surrounding domestic violence, oftentimes many of these listed below here are not even technically illegal and do not have any sort of recourse in the criminal legal system. So we want to talk about these public health definitions because they do include this broader range of controlling behaviors that can impact health. So for example, we have emotional abuse, social isolation, financial abuse, which might be described as doing things like taking control over a partner's finances, not allowing them access to using their own paychecks, or maybe using their credit to take charges out on something that's not actually for them or for the family, things like that without their knowledge. There's also stalking, and then intimidation and threats. So if you can share in the chat if there are any other elements of intimate partner violence that you're aware of that might fit into some of these categories, or expand a little bit more on some of the more broadly understood definitions of domestic violence, like physical or sexual abuse, that you think are important to bring into the space. And Anisa, if you could share those ones out for me if they come in.
Sure. So far, it looks like we don't have any, but I'll keep an eye out. Looks like we're not having any additions in the chat.
Okay. I'll just add on a couple then. Reproductive coercion is another form of intimate partner violence that we often notice in healthcare settings. And that might include things like pregnancy coercion. It might also include asking someone to get an abortion if they don't want to, or manipulating their birth control. There's also forms of spiritual abuse. So that could include mocking or demeaning someone's spiritual practices, and then many different forms of abuse that could fit into some of these categories listed here on the slide. Okay. So for our first Slido that we'll be doing today, we'll have you go to slido.com. You can also, if you're using your phone, scan this QR code and it should take you right to where you need to go. And then you can enter this code 9778. And we're hoping that you can share a little bit about why you think someone might stay in an abusive relationship. And as your answers come in, they should just populate on the slide right here. So we'll just be able to see as you share in the Slido.
And let us know if you're having trouble using the Slido, but I did drop in the URL and the number in the chat as well.
Okay, I see some responses coming in. Finances. Yeah, exactly. So someone may not have the financial stability to be able to leave a relationship. Maybe you're on a lease together. Maybe you share a lot of financial assets. So leaving doesn't feel like an option for those reasons. Isolation, like we just said, one of the tactics of abuse is making it so there are less connections to friends, family, maybe even coworkers. So it might make it feel like I have no one to turn to. That also feeds into what I see someone else here has shared as lack of support, low self-esteem. Housing can definitely be an issue. So maybe the choice to stay in a relationship feels more important than not having housing anymore. Education, so maybe understanding of abusive dynamics in relationships. Children is a big one that's showing up here, absolutely. So sharing children with someone who is hurting you can absolutely be a huge factor of why someone might choose to stay. Let's see, lack of documentation. Cultural expectations, so that might involve reasons why staying in a relationship is valued, or certain types of behaviors that are seen as normalized, or also just maybe connection to the person who's abusing you's family or their extended networks, and not necessarily wanting to leave those connections as well. Let's see, feeling that they deserve the treatment. Generational dynamics, so maybe abusive relationships have been something that that person experienced between their parents when they were a child, or their grandparents, or other folks in their family. Immigration status, it might be safer than leaving for fear of retaliation. Threats of suicide from the abuser, this is pretty common. The cycle of abuse, thank you for bringing that up. So there is that phase where maybe you do reconcile, there's an apology, you feel like maybe that the abuse is not going to happen again, so then someone might choose to stay because of that. Family, perception of love, mental health concerns. Great, thank you so much for sharing these. I have some of these outlined on the next slide, so this means that we can go through them pretty quickly, because I feel like y'all touched on pretty much all of them. Okay, so I'm gonna keep moving. And thank you again for participating in that. We'll have one more Slido come up. So if you have it on your phone, I would say just go ahead and keep it pulled up for now, just so you can participate in that second one. So here we saw some of these in our word cloud. Some reasons why people might say that have more to do with fear might be increased danger for self or children. So some common tactics that abusers may use would be to threaten to call ICE, say if someone in the family is undocumented. They may threaten to call Child Protective Services and make something up or share something that could potentially be triggering for Child Protective Service involvement in the family. They may be cut off from finances or documentation. A lot of you touched on that with housing security. We talked about that with financial abuse. Documentation might be things such as birth certificates, Social Security cards, things that someone might need to be able to leave a relationship and establish themselves outside of it. I also saw quite a few answers related to this third bullet point here around depression, anxiety, guilt and or shame, undermining the confidence to leave. Some other reasons that are rooted in love and hope and values might be a belief that the abuse will stop, or hope that the person using violence will change. Maybe there's better opportunities for the children. So it could mean that living with the person who is using violence means that the children have access to a much better school that they wouldn't otherwise be able to go to, or access to resources and finances that they wouldn't otherwise have. Someone mentioned this too, that the survivor is in love with the person hurting them. I think that this is a really powerful reason to keep in mind that it's not always just bad times all of the time or abuse. These are real people and real situations, and there's oftentimes love involved. I brought this up earlier, love for the extended family and network, and then beliefs about marriage and divorce. So just a couple final notes here, just noting that it does take an average of about 7 times to leave an abusive relationship. It's not always the goal either. Oftentimes the goal might be for the abuse to stop and to maintain that relationship without the violence moving forward. Abuse may not always be the most pressing concern. So for many of those reasons that we all just listed together as a group and many more, and then also personal and family / cultural values influence attitudes towards intimate relationships. So this is not to say that violence is normal or acceptable in any sort of culture or tradition. It's just to say that people have different perspectives when it comes to their relationships and how they think about whether or not they might want to stay or leave, and what factors are going to determine that. So now I'll hand it over to Anisa to talk about some of the specific ways that migrant farm workers can be impacted by domestic violence.
Great, thank you, Abby. So thinking about the experiences of farm workers in particular and some of the systemic oppressions that are at play, we wanted to mention both language barriers and exclusion from employment and labor protections, which of course many of you already know, but we want to bring this in the context for thinking about intimate partner violence as well. So according to 2015 to 2016 data from the National Agricultural Workers Survey, 77% of farm workers speak Spanish. And over the last few decades, there are a growing number of indigenous farm workers, particularly from Mexico and Guatemala, who speak languages other than Spanish as their primary language. And farm workers are also excluded from many federal and state employment and labor law protections. And this includes overtime protections, collective bargaining rights, and in some cases, minimum wage protections. So the exclusion of farm workers from basic protections results in low wages, less safe working conditions, and fewer protections from exploitation. And these exclusions have persisted for decades. And for anyone who is interested, you can find more information on the exclusion of farm workers under state and federal employment laws from the Farm Worker Justice Program's online interactive maps of these laws. And you can see the URL here on the screen. And next slide, please. So poverty is also common among farm workers. About a third of farm workers, according to this data from the same National Agricultural Workers Survey, 2015 to 2016, about a third of farm workers had family incomes below the poverty level. And the annual income for an individual was roughly $17,500 to just under $20,000. And the annual income for farm worker families was roughly $20,000 to just under $25,000. And the average hourly wage was $10.60. And most farm workers don't receive commonplace benefits like sick leave, paid vacation, or health insurance. And just a note too, that migrant workers' family incomes fell below the poverty level at a much higher rate than settled farm workers' family incomes. So it was about 52% compared to about a third. And unauthorized workers were much more likely than authorized workers to have below poverty household incomes, about 38% compared to 28%. And there are also additional challenges and barriers to accessing care for LGBTQ farm workers. So according to this publication, which you can see the thumbnail on the screen here, publication is promoting healthcare access to lesbian, gay, bisexual, and transgender farm workers from the National LGBT Health Education Center and the Farm Worker Justice Program. So they share that there is no data regarding the number of LGBT individuals in the farm worker community. However, outreach workers, clinicians, and researchers who provide healthcare and public health interventions to farm workers know from experience that LGBT people exist within the community and that many of them face enormous challenges in accessing care, finding support, and feeling safe. And additional structural oppressions make it more challenging for LGBTQ plus farm workers to access care such as homophobia, transphobia, and in addition to challenges such as housing insecurity, discrimination, poverty, and economic insecurity. And next slide, please. So we know that intimate partner violence impacts all communities and segments of our society. And while we are not aware of reliable national data on the prevalence of IPV in farm worker communities, we are sharing these intersecting and overlapping forms of oppression and marginalization because we know that they create vulnerability for farm workers experiencing IPV, which may impact their health and access to healthcare and other supporting services. And this, of course, is only being magnified by the pandemic, when low-wage and essential workers especially are even more isolated and experiencing economic hardship. So we did want to share a few points of experiences of IPV survivors that may also intersect with settled and migrant farm workers as well. So with regards to immigration enforcement, which we hit on a little bit earlier, studies have found that immigrant and non-immigrant communities experience domestic violence at similar rates, but immigrant survivors may fear reporting abuse or accessing services out of fear of possible immigration enforcement actions. And then similarly, there's data that suggests that rural survivors may also have more difficulty accessing services. And then, of course, when services are lacking, survivors are less likely to report or disclose or receive services that are crucial for their immediate and long-term safety and overall well-being. So domestic violence programs in rural areas are often also short-staffed and not able to offer the same amount of services, which means that survivors are twice as likely to be turned away as survivors in rural areas. And next slide, please. So we wanted to hear from you and ask, I know a lot of you are health providers and working within health centers. We wanted to ask if you have seen an increase in patients or the folks that you're working with experiencing IPV throughout the COVID-19 pandemic. And you can use it's the same Slido link, so slido.com, and enter the number 9778, or you can use the QR code on the screen as well. Okay, so it looks like there's some yes, a slight increase, some no, some I don't know, yes, significant increase. Okay, we'll just give it a couple more seconds. And some of you have indicated that your agency does not assess for intimate partner violence. Okay, and for those of you that answered yes, either slight increase or significant increase, I'd love to hear if you want to share, feel free to just drop in the chat, just any dynamics that you're noticing or any experiences that you want to share. And remember, you definitely do not and should not share patient information, so don't feel obligated. You can keep it totally anonymous. All right, well, feel free to chime in later as well. But I did just want to note that, yeah, it looks like a lot of you have seen pretty significant or even slightly increases in disclosures of intimate partner violence during the COVID-19 pandemic. So in just a little bit, we are going to be talking about our clinical intervention to address IPV in health settings. Okay, and I'm going to turn it back to Abby.
So here are some of the things that the National Domestic Violence Hotline has heard from survivors of domestic violence throughout COVID-19 pandemic. I believe this information was actually collected pretty early on in the pandemic. I'll just highlight a couple of these. A caller said that they could not file paperwork to remove the abuser from their home because courts are closed due to COVID-19. A chatter also mentioned that the abuser was using the virus as a scare tactic to keep the survivor away from their kids. And then finally, a chatter stated that they have known for a long time that there were red flags in the relationship, but things are escalating with the pandemic and they can't even go to therapy. So these are not necessarily unique to COVID, but as you can see that some of these may have been amplified by COVID, especially with the closure of certain services and increased isolation and amount of time being spent in the home. Some other unique controlling behaviors that we wanted to highlight that might relate to working within migrant farm worker communities could include threats of deportation, like we've said, taking kids outside of the US, lying about immigration status, forbidding English classes, or holding on to important documents. Okay, so as service providers, how can we better work with people who are experiencing intimate partner violence in our settings? One of those ways is moving towards a trauma-informed care framework. Away from what's wrong with you to what happened to you and how can I support you. So these bullet points here are some of the tenets of trauma-informed care. like safety, which includes both physical and psychological safety. So it's not just the physical setting, but it is also the interpersonal interactions that you have with patients, clients, participants that are really important for promoting safety. Trustworthiness is really all about transparency. So it includes transparency in organizational decision-making, transparency among staff, and between providers and patients. Peer support is really referring to people with experiences of trauma and being able to support each other moving through that. And there are ways that you as an organization can set that up for folks depending on the different services that you provide. Collaboration and mutuality, or leveling or minimizing power differences within an organization or health center, can be really important. This can be like shared decision-making could be an example of this. Empowerment, voice, and choice. So this emphasizes the impact of differential power and emphasizes the importance of individual voices and shared decision-making once again. And then there's also cultural, historical, and gender issues, which recognizes the power of lifting up cultural traditions and connections, incorporates a race equity lens in decision-making, and recognizes the diverse needs of patients and staff. Okay, so some of you may also be familiar with vicarious trauma, which is basically a change in one's thinking or worldview due to exposure to other people's traumatic stories. So this is really common among people who are working with trauma every single day. We also talk about burnout pretty regularly in the field, which is a little bit different from vicarious trauma. It's a syndrome of emotional exhaustion, depersonalization, and a reduced sense of personal accomplishment, and it can develop as a result of general occupational stress. So it's not necessarily tied to that empathic response to hearing stories of trauma all day, but can often be more associated with the work environment. So this third concept here is one that we really wanted to uplift because I think that it's also really important when we're talking about vicarious trauma that we also highlight the importance of vicarious resilience. So these are strengths that come from working with people who have experienced trauma. So witnessing others overcome adversity, recognizing people's capacity to heal and take care of themselves, and reaffirming the value of the work that you do. So rather than only thinking about it as the negative impact that working in trauma can have, vicarious resilience really lifts up the way that witnessing all of these all of these listed on the slide and more can really bring strength to us as individuals and also help us move forward in this work. Okay, so something else that's really important for health centers and domestic violence program partners is recognizing the value of partnerships. So nobody can do this work alone, and we all have to work together to be able to provide the most holistic services that we can. Anisa is going to drop in the chat some resources for establishing partnerships between community health centers and domestic violence programs. You'll see that there is a sample MOU that you can use if you're connecting with a local program. There's also some ideas and worksheets that you can look through to see what type of services you provide at the health center, for example, or if you are from a domestic violence program, how you might be able to make some bidirectional warm referrals to each other. One example of this might be if you are a community health center offering to do healthcare enrollment at a domestic violence shelter on a weekly or monthly basis, depending on how many new shelter residents are coming in through the shelter. So for those of you who are not as familiar with the services that domestic and sexual violence advocacy programs can provide, we just have a few here that we wanted to lift up for you. Generally, there's an element of crisis and safety planning. Almost always it's a 24-hour hotline. Sometimes there's assistance with housing or transitional housing. There can be legal advocacy, forensic exam accompaniments. So for example, if someone experiences a sexual assault, oftentimes these organizations will be able to go with them to the hospital and be there with them while they're getting the evidence collection or just the medical care that they need during that time. There's often support groups that can be offered or one-on-one counseling, either therapy or peer counseling. children's services, and finally employment support. So some additional resources are these national hotlines that we have here. They are toll-free and offer multilingual interpreters. They're confidential and anonymous. So the National Domestic Violence Hotline responds to calls 24/7 and provides one-on-one support to each caller and chatter, offering crisis intervention. They also offer options for next steps and direct connection to sources for immediate safety. There's also the Trevor Project, which is crisis intervention and suicide prevention for lesbian, gay, bisexual, transgender, and questioning young people, ages 13 to 24. We have the National Sexual Assault Hotline, which connects to a trained staff member from a sexual assault service provider. And then there's the Strong Hearts Native Helpline, a safe, anonymous, confidential service. And let's see, finally, we have here the Trans Lifeline Hotline, which is dedicated to the well-being of transgender people. They run a hotline staffed by transgender people for transgender people. So I'm going to pass it back over to Anisa.
Great, thank you, Abby. So as we mentioned earlier, the work that Abby and I do at Futures is really focused on the health impact of intimate partner violence, as well as improving the healthcare system's response to IPV. So we wanted to share that there are a number of long-lasting health consequences for IPV, in addition to what folks usually think about, which is the immediate bruises and more physical injuries. And these health consequences can really persist even after an abusive relationship has ended. And so you can see a number of them here on the slide. And we also wanted to note that while these specific health consequences are what the research shows, there could also be a number of health conditions that are associated with intimate partner violence. And this also includes behavioral and mental health issues. It can also impact relationship difficulties, and then also how people present and interact in their lives because of the abuse and the trauma that they experience. And a lot of times we also mention that sometimes if we're working with patients or clients who we might think as quote unquote difficult or like non-compliant, these might actually be folks who are experiencing violence and abuse. And next slide, please. So because of the isolation that survivors experience and lack of access to supportive services and social support networks, healthcare providers can really be a lifeline for survivors. They might be the first responders for people experiencing intimate partner violence, also trafficking and exploitation, which we often integrate into our work. They might be one of the only other people that your patient is allowed to speak to. Providers might be the only kind words a patient has heard. And providers might also be the only access to information on help and safety. And so, and especially now during COVID-19, it's just really important to think about just this crucial role that health providers can have and can have a positive impact on the lives of survivors. And next slide, please. So an important point that we want to emphasize today is that when working with survivors, we are wanting to redefine what success and safety looks like. So a lot of times we as helping professionals are trained to fix things or make things better. And sometimes that might mean a person is leaving a relationship so that they are safe or safer. But we want to stress that this can really never be the goal of working with survivors, because as we talked about earlier, we know that leaving or ending an abusive relationship can be the highest likelihood of homicide or acute victimization. So the safest thing might actually be to stay put. And so we really want folks to move away from this idea of asking why survivors haven't left and moving towards asking, how can I support this person so they can make their own decisions and choices? And that's really the framework that we're looking at. And it's also really important because a lot of times the experiences of survivors, their autonomy and choices have been taken away from them. So this is another really important aspect in why we want to redefine what safety and success looks like. And next slide, please. So in addition to establishing formalized partnerships with advocacy programs, which we mentioned a minute ago, we also promote a clinical intervention called CUES. So this evidence-based intervention is to address intimate partner violence. And it features this small safety card tool, some of which you see here on the screen. So CUES stands for confidentiality, universal education, empowerment, and support. And those are the steps of the intervention. And I am going to just drop an example of one of our safety cards into the chat. And just know that we usually have this a physical copy in person. And so this is a PDF, and that's why you'll see that the panels look like they're a little bit out of order. So I'll talk about that more in just a second, but feel free to open it. So this really differs from a traditional screening approach, our CUES intervention. So in a traditional screening approach, a provider will ask direct questions about experiences of violence, but it's really dependent on a disclosure to share resources or make warm referrals to supportive resources. And we've learned through research that the use of structured screening tools does not promote disclosure or in-depth exploration of patients' experiences of abuse. And we found through research that patients are more likely to discuss experiences of violence when providers initiate open-ended discussions focused on parenting, safety, or healthy relationships. So CUES is what we call a universal education approach that encourages providers to talk to all their patients about healthy and unhealthy relationships, how it can impact their health, and where to go for support if needed, which includes making a warm referral to a partnering advocacy program, which is why we really emphasize the importance of the health center and advocacy program partnerships. And we found that we can reach more patients this way because it does not depend on a disclosure in order to share resources. And we also know that survivors might not disclose their experiences of violence for a number of reasons, including shame or fear of judgment. So CUES features, as I mentioned, this small safety card. And so feel free to open the one I sent in the chat. And just to note that we do have a number of different safety cards. They are tailored to different communities and different settings. So some of the ones you see here on the screen, that one in the middle is our adolescent safety card, which we have. Many of our cards are available also in Spanish. They're all in English. Many of them are translated into Spanish. We also have some available in other languages, including Armenian, Tagalog, Arabic, and Farsi. And we also, as I mentioned, have them tailored to different communities, including for home visitation settings, for HIV testing centers. We have some for folks who are currently houseless as well. That's the one at the top there. We have one for Muslim youth. And so really it goes on and on. So the one I dropped in the screen is the one, it's specific for primary care settings. And while you can see right now it's focused on women, we are hoping to move it to make it gender neutral. And we are working on this year, we'll be developing one that is specific to community health centers. So we will definitely keep you all posted about when that one is going to be available. So each card, when you see it in person, it's actually the size of a business card. So about 2 by 3.5 inches. And it actually unfolds. So it's 4 or 5 double-sided panels. And the safety card really serves as a prompt for providers to initiate conversations with patients. And we encourage them to give 2 cards to each patient, one for them to keep for themselves, if it's safe to take home, and one to give and share it with a friend. And our research has shown that patients have reported feeling really empowered when they are able to help others. And next slide, please. So here are the steps of the intervention in a little bit more detail. So the C stands for confidentiality. And this is where we promote the importance of seeing patients alone for at least part of the visit, and also disclosing any limits of confidentiality. And as you can imagine, this looks a little bit different with telehealth, and we have adapted this approach for telehealth, which I'll share in just a couple of minutes. And the UE stands for Universal Education and Empowerment. And so this is where the provider, as I mentioned, would initiate this conversation and share 2 cards with their patients. And there's a sample script here on the screen that providers can use. And then it's not, of course, necessary or even logistically possible to go over all of the slides. So we just suggest that providers open the card and just point to 1 or 2 panels. And again, we have a sample script on the screen just saying that this talks about healthy and safe relationships, ones that aren't, and how they can affect your health. And on each of the cards, it also has on the back, there are hotlines. These are national hotlines for where patients can reach out if they need it. And so that's where the S comes in. The S is for support. So not only do we suggest that the providers point out the resources on the back of the card, but this is also where it is so crucial to have that partnering advocacy program, because the providers can actually make a supported and facilitated warm referral over to their partnering advocacy program. And they can even offer to make that phone call right there in the office. And ideally, they know the name of the advocate, their services, where they're located. And this really increases the likelihood that a patient will follow up. And this, of course, is just to offer it. And if the patient agrees that they would like it, then the provider can help initiate that referral. And next slide, please. And so we are running a little bit short on time. So I will just mention that we have adopted this approach to be used in telehealth settings. It is similar, but of course, the difference is providers have to take different steps to think about how to enhance privacy during telehealth visits. And also the physical safety card is not given. And so we instead have some sample texts that we can share. And that's how we've adopted it for the clinical setting. And next slide, please. So the essence of cues is really about these elements that you see here on the slide. So it is about building relationships. So it's about building that relationship between patients and providers. It is also strengths-based caring. So this means the provider is avoiding judgment or victim blaming and instead focuses on the strengths that a patient has. It also improves access to advocacy services by making those warm referrals we talked about. It also empowers clients and the folks that they care about by having access to this information and being able to share it with others. And then it also shares the power of between the provider and the client, because the patient themselves is able to share this information with others as well. And next slide, please. And I'm going to hand it over to Abby.
So we just want to expand a little further on the S, where you're providing support and say a patient does disclose that they are experiencing intimate partner violence, for example. These are just a few suggestions of some things that you can say before offering a warm referral. Because it is really important the way that you respond rather than just immediately jumping to how to connect them to services. There's really this opportunity for a moment of connection between you and the patient. So you'll see here some things that you can say are pretty basic, but can be really impactful. So I'm glad you told me about this, and I'm so sorry that this is happening. No one deserves this. You're not alone. Help is available, and you get to choose what you do next. You can also say something like, I'm concerned for your safety. I have some of these referrals for you that may be able to help you plan around some of those safety concerns if you're interested. So just as this slide says here, your recognition and validation of the situation are really invaluable. So after you've provided some of that initial support, acknowledging that the disclosure happened and letting them know that you're there for them and that you're willing to connect them to any services that they need without pushing those on them or trying to coerce them into connecting to services, you can provide that warm referral. So this is really where that partnership with the local DV program comes in. So an example we have of the way that you can make that suggestion would be, if you would like, I can put you on the phone right now with the name of your local advocate, and they can help you make a plan to support your safety. All right, so just to kind of wrap up this CUES intervention, we just want to put this in the context of the public health approach again, the public health approach to violence prevention, which requires an understanding of the root causes of violence. So this chart is the 4-level social ecological model of violence prevention that comes from the CDC. It shows us that there are individual, relationship, community, and societal factors that contribute to violence. So in order to prevent that violence, we should have strategies that reach each of these levels. A multi-pronged approach will be much more effective than any single intervention will be. So I'm just sharing this to say that the CUES intervention is more so along the interpersonal or the individual level of intervention. It could potentially become a community level practice if it were something that were widely practiced by different health centers or different service providers as this universal education approach. But we just really wanted to make sure to situate this as something that you can do on an interpersonal level, while acknowledging that there are still societal level interventions that need to be made in order to prevent intimate partner violence from happening in the first place. So that would be laws, policies, and legislation that make it so there are not those environments like the inability to leave a situation that's abusive because there's no access to housing, or because of financial abuse, a survivor is not able to leave their situation because all of their finances are tied up in that relationship, as an example. Okay, so now I'm going to hand it back over to Anisa to share some information real quick about resources and some upcoming learning collaboratives before we get into our Q&A.
Great, thanks so much, Abby. So as I mentioned earlier, Futures Without Violence is home to the National Health Network on Intimate Partner Violence and Human Trafficking. So we are funded as a training and technical assistance partnership for federally funded community health centers nationally. And we actually just launched last summer. So we just wanted to make sure everyone is aware, because I know folks, a lot of folks here from community health centers, that we are available for ongoing training and technical assistance on this topic. And next slide, please. And these are just a couple of our upcoming activities from the National Health Network on IPV. And we will share our emails at the end of the presentation so you can get on our mailing list if you would like to join these. And we do have an upcoming webinar later this spring in collaboration with the Farmworker Justice Program, so it's going to be on a very similar topic as well. And next slide. And then this, we mentioned earlier, is our go-to resource for building and sustaining domestic violence programs and community health center partnerships. So I will drop the link in the chat again, and I'll drop the link to our National Health Network homepage so you can learn a little bit more about us. And we want to make sure that we have time for questions. So we'll go ahead and we'll move on to that. And in the next 8 minutes or so, we'd love to just open it up for questions and just hear from you and see if y'all have any thoughts or comments on what you just heard today. Okay, and Kim is asking, is labor trafficking part of the definition of human trafficking for you? H2A workers have experienced tremendous intimate partner violence during the pandemic because of isolation. Yes, thank you for that question, Kim. So today we were mostly focused on intimate partner violence, but as you know and just heard, our National Health Network is expansive to include human trafficking and exploitation as well, which does include labor trafficking and exploitation. So we are going to be developing and the CUES approach can be adapted for labor trafficking and exploitation as well. And so I can follow up. If you want to email me, I can send you, we have some slides with some sample scripts. And also with that safety card I mentioned that is being developed for community health centers, that will be inclusive of trafficking, including labor trafficking as well. So thanks for that question. And while folks are thinking, I'm going to go ahead and drop in the link to our homepage for the National Health Network We are working on building out a new website, but for now we have this landing page on our Futures website. And here is where you can find out about any upcoming webinars. We also have learning collaboratives, as we mentioned. And feel free to email Abby or me, and we can make sure you get on our email list to make sure you stay up to date with any upcoming activities. Well, since there are no other questions, well, I guess we can leave it open for a minute, but just so you know, our email addresses are right here on the screen. But we do still have a few more minutes, so feel free to hang on and share any additional questions or thoughts or comments you have. Also, feel free to email both of us. We would love to, we're totally available for additional technical assistance. Abby has been doing a lot of work around establishing MOUs and working with health centers and establishing MOUs. So if that's something that's of interest to you, I know I'm putting Abby on the spot, but I'm sure she would love to help with that.
Yeah, especially if you're interested in joining us for one of those 2 learning collaboratives, please feel free to reach out to me, because part of my role in that is helping you identify a local domestic violence program partner. So I'm willing to meet with you one-on-one and talk about some of the services that you provide, figuring out how to make those connections to those providers and get that partnership moving. So definitely reach out if you're interested, but even if you're not planning to apply for one of the learning collaboratives, please still feel free to reach out as well.
And I should also mention too that our safety cards, so you can actually order them from, let me put the link here in the chat, it's store.futureswithoutviolence.org. So we are able to ship physical copies. Right now it's a little bit more limited just because we are mostly working remotely. They're free of charge, but we do have a flat shipping fee just to offset some of the costs. However, you can also download PDF copies of our materials for free. So that's an option for you as well.
Thank you so much, Anisa and Abby. That was a really great presentation with a lot of information. I bookmarked a lot of the resources that you plugged into the chat. I love that. Thank you.
Yes, thank you so much, everyone, for having us. We've really appreciated being here.